So, this is my this is Intro to Menopause. What we will be kind of covering today is what is menopause, who does it affect, just a brief background about the kind of science behind it and the biology behind it. Why is estrogen so important and its effect on our body and its effect when it starts decreasing and how that affects our body. We'll go through very briefly kind of the short-term and long-term symptoms, and that will lead us nicely on to the next presentation, which is about treatment options. So if I start off with what menopause is, medically, it's known as a retrospective diagnosis where your periods have stopped for over 12 months, and it has to be consecutive. And usually that's because of kind of it's a natural loss of ovarian follicular activity. And there's no other causes that may be contributing to this stoppage of the periods. However, after speaking to loads and loads of patients, loads of women, both as a doctor and personally, menopause is different for every single woman, and every woman will go through it, often in the latter third aspects of their lives, but not necessarily. Um, it's so much more than periods just stopping. I think that's the good bit of it. All the other stuff that happens with it, which is changes in your physical body, your brain function, how you identify with yourself as a woman, your place in relationships, how you conduct yourself in relationships, self-confidence, and overall your well-being in general. And the changes can be a few things to a lot of things. And for each woman, it's very, very individual. But from what I understand is, we hear about it, but nothing ever kind of prepares us for these biological changes, and each woman has to go through it to fully understand menopause and their experience with menopause. So I think it's more than just period stopping. It's a journey, so to speak. So I wanted to talk about kind of the background. So just so it gives you some context, um, we women are born with a set number of kind of eggs, if you will. And while we're in utero at 20 weeks, there are 1.2 million eggs, around that we have. By the time we hit puberty, that number has declined to 300 to 500 number of eggs. So going from 1.2 million to puberty, which can be from anywhere from 10 to 15, it's jumped significantly and it's gone down. Then after 37, there is a very fast decline where we're looking at less than about 50,000. And then at 51, we're less than 1,000. Why is that important? Number one, our eggs are what, well, the ovary produces these things called follicles, and that's what's responsible for releasing these important hormones in our bodies, such as estrogen, progesterone, and various other hormones that work with them to kind of regulate us and to allow our bodies to function the way they do. Um, as we get older, the quality of the eggs also changes because this is a non-renewing process. Um, our 13-year-old eggs are 13 when we're 13. Our 41-year-old eggs are 41. So as we get older, those eggs also will age with us. So the integrity and the quality of these eggs will also change. And that means how it responds to hormones and how it releases hormones also changes. Um, so right now in the UK, the average age of menopause is defined as 51. Um, and it can be defined, the whole kind of menopause journey can be defined as premenopausal. So that's any time from when you get your period to when you don't have your period, or changes in your period. Perimenopause is that phase just before the periods actually stop. So a lot of the times in perimenopause is when you'll start getting those irregular periods, the heavy periods, um, night sweats. It's that flux, so to speak. Menopause is, I would say, the the stopping of those 12 consecutive periods. So that is defined as menopause. And then it's after, so post-menopause. That's what our body will kind of do as it's responding to this lack of estrogen and this declining amount of estrogen. So those are the phases. This is just a really, really brief slide looking at kind of the hormones and the interplay of the hormones. So as you can see in kind of this slide, this is the estrogen and it's kind of going up and down. And this is that perimenopause phase where it can peak. It all depends on the type of egg you get. So if you get a good egg 1 month, great, your symptoms might be less, but if you get not so great of a quality of an egg, your symptoms might not be so good. So that's why for menopause, we do not use blood tests because of this kind of up and down variation. Because 1 month we might have a good FSH, we might have a good egg, as I said, and so the blood tests will come back normal. We diagnose menopause with clinical symptoms unless you are under a certain age, and then blood tests will be more useful, which I'll talk about in a bit. Another important thing to see here is the testosterone. So you can see that estrogen goes through this kind of up and down wobble, and then it slowly goes down. But the testosterone kind of stays kind of stable, and then it goes down a bit slower. So in that postmenopausal phase, it's that androgen or that testosterone that is maybe the most prominent or more dominant hormone that's present post-menopause. Going back to just briefly the other types of menopause that we can get. So menopause before the age of 40 is defined as premature ovarian insufficiency. And that is when you have a decline. So as I said earlier, from 35 onwards, we have this rapid decline. And for some women, that might be even faster or sooner. So they're looking at lower levels of oocytes or eggs at a younger age. And so that is when blood tests become helpful. So we need to rule out any underlying causes, whether it can be something else like your thyroid or various other things. And then we look at the hormone levels then, because we would expect them to be in a certain range. That's when kind of the blood tests are very helpful. Induced menopause is when we have a medical cause or a surgical cause for menopause. And that is when you have a hysterectomy where you remove the eggs as well. And that is called surgical menopause. It can also be due to chemical menopause, which is when we give medications for certain instances like cancer, where we're knocking off kind of the higher hormones that are messenger hormones for the whole reproductive cycle. Patients who might be in this situation are patients who might have opted for a total hysterectomy because of endometriosis, because of fibroids, because of cancer. And so that is also a different type of menopause. And often women find this induced menopause quite difficult because it is a sudden stopping. The whole kit and caboodle is removed and it's quite sudden. And there are a lot of emotional and physical symptoms that they might feel as opposed to natural menopause where it's more of a gradual change. Moving on, I wanted to just briefly touch upon kind of menopause in ethnic and minority women because obviously New Malden, Southwest London is a very, very culturally diverse population. And so lots of women are going to be experiencing different types of menopause. Also culturally, how menopause is discussed, how periods and reproduction is discussed will vary in these communities. And some communities don't talk about it at all. And we have this kind of just get on with it type of attitude. So I think there's little data. There is some data, but there isn't a lot of data out there specifically looking at kind of ethnic or racial differences within menopause. There was a study in 1996 called the Study of Women's Health Across Nations, which was looking at exactly that, different cultures, different ethnicities, different races, and how menopause affects them. So some of the from the British Menopause Society, some of the facts to be aware of is African and Caribbean women of that descent, menopause is usually around 49 years old or a bit earlier. They tend to suffer with a higher incidence of vasomotor symptoms, so hot flushes and night sweats. Um, Southeast Asian women have less hot sweats, but have increased joint and muscle pains and may suffer with more low libido and sexual and pain on having sex. South Asian women, the age of onset for menopause is a lot younger, so it's 46 to 47. And also, because of our genetic makeup, we are at more risk of developing cardiovascular disease, diabetes, central obesity. So, menopause can affect that risk factor quite significantly. Now, my favorite part of this subject is kind of the biology behind it. So I'm just going to try to whiz through this as quickly as I can. But basically, from everything I've read, estrogen is the key. So I think menopause was evolution's way of killing us women off because once we weren't useful fertility wise, it was saying, okay, so how can we get rid of these women? And estrogen was the big kind of key to it sustains us and the lack of it all affects us. So it's almost essential in everything. It's almost like a battery cell. So it helps kind of allow glucose to get into our cells. It provides energy. It's almost involved in every single biological system in our body, not just the bikini area medicine, which is breast and lower region. It affects our bones, our brain, our immune system, cardiovascular health, and it works through receptors that are, again, all over our body. And so not having this very, very vital estrogen or a decrease in it, that's what leads to the effects that we're feeling. So the brain fog and the various symptoms. Now, going on to symptoms, some of the first things women might experience, these are short-term symptoms. So when I say short-term, that's a very relative term. So changes in period. So women might report irregular periods. Some women might have heavier periods with flooding, lots of clots. Some women might have shorter periods, which are lighter. It really varies, but really it's kind of that 28-day cycle might change. So you might go for months without a period, and then you might get one. So it's that flux of those eggs. So one month you might have a good egg and you might have a regular period, and another month you might not have such a great one. So that's kind of why you have these fluctuations in period, and it's the persistent decline in follicular activity that is when we don't have periods at all. One of the most common symptoms and one of the most kind of debilitating symptoms is the vasomotor symptoms. So that's like hot flushes, night sweats. They can be associated with symptoms of palpitations and anxiety. Um, Most often than not, 75% of menopausal women will experience this, and 30% of those women will find these symptoms to be severe. It can last up to 7 years, and often it's most prevalent or most felt in the first year after your menstrual period. Sleep disturbances, insomnia are another common cause, and that could be also due to the hot flushes. It could be due to your mood, anxiety. Um, Often women are saying that they find it difficult to fall asleep, or what they're finding is that they wake up in the middle of the night and are not able to get back to sleep. And as I said, that could be due to those things like the hot flushes. Um, Women find that they get restless leg a lot more, and that's a contributing factor. So it's when you can't get comfortable, you're constantly moving, you've got to get out of bed, or sometimes having to pass urine. A lot of the times your bladder function changes and how you pass urine also changes. So that could wake you up at night. Obviously, that leads to not having that sleep, and that is a domino effect. So you end up feeling more fatigued. It might contribute to the brain fog. You might contribute to your changes in mood. It might prevent you from working out. It affects our work, our relationships, and overall, it goes back to causing that stress and anxiety. And sometimes, that not being able to sleep is that stress and anxiety, and it goes in this horrible cycle. Um, in some cases, we use alcohol and medications to help us sleep. So it has a knock-on effect. And this is just a simple slide about kind of the lack of sleep and the effect that it has and the increase in stress hormones and how that impacts our body. A lot of women will feel an increase of migraines. So one of the symptoms they might find is they're having a lot more intense migraines. Um, Lots of women who go through surgical menopause tend to feel these migraines more, or the frequency is more, they're more intense as opposed to natural menopause. An important thing to mention here is it's not like contraceptives where, there are contraindications to having uh, the contraceptive pill because estrogen can be given topically. It's safe to have these hormones if you have migraines with auras. Obviously, I mentioned the mood, and I just wanted to add to the mood. It's also things like premenstrual syndrome. So if you had that beforehand, that might be a bit more intense during the perimenopause and menopause phase. So what that is where, you feel like a completely different person. You might feel completely um, like you might murder everybody, and you might feel like you don't feel like yourself. And then once you get your period, that kind of settles. So that kind of mood changes could be more persistent and more intense during the perimenopause and menopause phase. Another thing to mention is kind of in our society, we're completely geared up to be thinking about youth and this unattainable version of beauty and what's normal. And so sometimes these changes can affect our feelings of self-worth, our ideas of aging, what's normal. It has a kind of knock-on effect into our self-esteem, and overall, it has an impact on our quality of life. One of the key things women will also say is that their libido or their desire or their enjoyment from sex has changed after the menopause. And again, this is a multifactorial issue. So it's not just the hormone decline, it's how we see ourselves. It could be physical symptoms like vaginal dryness, finding it difficult to orgasm, changes to the structure in the skin down below. So there's a lot of things that can impact our libido and sex drive. There is something called hypoactive sexual desire disorder, where women do not feel any urge or desire to have intercourse or sex and don't get any pleasure or enjoyment from it. And in those circumstances, that's where testosterone becomes useful. It's one of it's clinically researched, and that's the main indication for testosterone. There's also weight gain and weight distribution. So a lot of women will describe abdominal weight gain, and that's because of kind of how the estrogen helps us put our weight around our bodies. And also, it thinks it's helping you by creating this extra fat, which can then be converted into estrogen, but it's not the estrogen we need. So, obviously, that will have impacts on our cardiovascular health and our overall well being. Cognition and menopause and it is a big area which is being more and more looked into, and the difference in female versus male brain. And so as you can see here, this picture here has kind of the areas where estrogen receptors are quite strong. So our higher executive function, our learning, our memory, our temperature control, which relates back to the hot flushes and vasomotor symptoms, our sense of emotion and motivation. So when these areas don't have estrogen, that's where we feel those impacts of the symptoms that I discussed earlier. This is a very busy slide, but it's just to kind of one of the main things that postmenopausal women tend to really come in with is kind of genitourinary symptoms. So vaginal dryness, itching, recurrent UTIs, um, prolapses, absolutely dreading their smear. I mean, we dread it anyways, but like even more so than usual. And that is also because of these changes from estrogen. It causes thinning of the skin down below, which means we lose collagen, elasticity. It affects the type of good bacteria that we have within the vaginal area, and it means without that good bacteria, the bad bacteria can be a lot can be quite higher, and that causes increased UTIs. It also causes an increase in kind of discharge and smell. The dryness can affect intercourse. It can affect how we perceive intercourse. And to make things even more complicated, our bladder has a lot of estrogen receptors in it. So our ability to kind of store urine, our sensory feelings of urine, and that urgency, that comes with the lack of estrogen and bladder control. Finally, kind of long-term effects of menopause. Why is it important to recognize and treat sooner than later? Estrogen is pivotal in our bone kind of restructuring. So it helps prevent bone breakdown, and it helps kind of stabilize our bones. And when we don't have that estrogen, what we get is more bone turnover and not laying of the new bone. So we're at more risk of developing fractures and osteoporosis. So it's important to kind of think about this and think about diet and lifestyle changes, which can help you. It really has an impact on our cardiovascular health. So estrogen is protective. It helps with oxidative stress of our blood vessels. It stops kind of endothelial remodeling. It helps the vasculature, our blood pressure control. And so and as I mentioned earlier, the fat distribution. So it has a protective effect when we're treating menopause, or trying to find lifestyle changes that can also help kind of reduce the risk. It's linked in diabetes, glucose metabolism, cholesterol. It helps make better. It makes healthy cholesterol, so it helps kind of regulate that. And obviously, just talking about dementia and depression, there are recent studies which show menopause, or the lack of estrogen more specifically, could be linked to an increased risk of Alzheimer's and dementia. And obviously, a persistent change in mood can lead to long-term symptoms of insomnia, anxiety, depression. And there's studies saying that there are increased risks of developing autoimmune conditions like SLE. Now, the important thing to raise here is women who go through surgical menopause or medical menopause, where everything is stopped very early, or possibly earlier than what they would have normally gone through. It means we have to vigilantly and proactively look at this kind of cardiovascular health risk and bone risk. So it's important for women to have DEXA scans when they're in that situation, when they're in a menopausal state for longer, to make sure we're looking at our bone health. Um, this is just a little something I found really assuring after my doom and gloom talk about all the bad things. But basically, there was a study, there are studies now about kind of menopause, the lack of estrogen, and brain cognitive function. And there was a study looking at a lot of women between the age of 40 to 65, looking at MRIs and different types of scans. And although it did show that the lack of estrogen did change our higher function areas, and there was less energy going to certain aspects of our brain, and there might be a link to developing Alzheimer's due to the APO4 gene. What it did show, which is what I'm going to choose to focus on, is that our brains will remold itself, will adjust itself for this new kind of phase of our lives. So we have gray matter volume recovery. We're great at neuroplasticity, so that means the brain reorganizing itself and making new neural connections. It increases brain connectivity. It's able to change kind of how the glucose metabolism is within the body and the brain, and so it compensates. And so that cognition change it's not permanent. The brain will find a way to kind of recover any losses, and I think that's really amazing. And to finish off, this study says things like new experiences, so going on holiday, meeting new friends, socializing, meditating, all these things increase neural connection. So there is science behind why you need to take that holiday. It's good for your brain. So use that and run with it, ladies. So that's the end of my talk. I've got a video that you can see later, but yeah, that's a whistle stop tour of what menopause is.